one theme or like question I know that I had been having, and also that I've been bouncing back and forth with Abby, was about the sort of the difficult territory that we're necessarily navigating, talking about substances that most people will associate with, their illicit versions, right? And I was thinking of some like other examples that kind of they point to what's different here, whether it's I still remember some of the early cannabis legalization stuff where it's like, we're going to give you your medicine, right? But the ads would sometimes have a little bit of like Flower People music in it too. So there's a slight like wink, wink kind of going on there. And I think I've seen some similar stuff too with psilocybin as well, where it's like there's a kind of a giving people their cake and having it too. But so I think a theme is this kind of relationship between like drugs as medicine and drugs as like drugs. And so that's one thing that we can kind of gesture at. And I was, so that's like, I don't know how like humorous we want to be about that either too. I want to respect.
No, you're touching on something that I think also has implications for who and how we engage with the world when we think about what we're doing. As a starting point, the fact that for me, my career has led me to a place where I'm directing the manufacture of large quantities of LSD is not something I would have anticipated being in my professional career at all, or my personal life for that matter either. But that feels strange, even when you do it every day. That there's an angle about that just feels like an unusual activity to be doing in one's life because of drugs history and because of, in part, that history has led there to be these enormous stakeholder groups and an enormously diverse set of people who consider themselves stakeholders around, let's say, the category of these drugs and specific drugs, of course. And many of them are quite validly stakeholders. They have a valid reason to have beliefs and opinions and vested interest in how these things end up being in the world. But boy, is that unusual for a drug development project that's like in phase 3. Rarely in psychiatry phase 3 do we have a lot of diverse stakeholders in the compound. And here we try to engage with those different stakeholders in a way that's respectful of their history, their beliefs about the category, while at the same time kind of having to force the acknowledgement that the project we're undertaking is drug development.
It strikes me, given that you also have a background in addiction medicine, that there must be like a little bit of cognitive dissonance. Or maybe not. I mean, we're talking about substances that are fundamentally not addictive.
Not in the usual sense, right? Not in the sense where you think about them being really deleterious to people's lives and creating patterns of use that people wish they didn't have. And so when my first startup as a doctor was clinics in Boston that were originally going to be just oriented toward opioid treatment. But as soon as you open the door to that, you end up doing psychiatry also if you're trying to really provide robust care. So the whole point of those was fully insurance supported, but very high quality care in nice places so that people would feel connection to the facility, to the providers. We required people who were getting buprenorphine treatment to also be in a program of psychotherapy, so that it was a very high touch involved sort of a clinical care paradigm. And the thing I came to from doing that a lot was that it still is about goals. It's still about people meeting their own goals. And just because someone walks in and says, I use opioids in a way I don't want to, and I'd like to stop, the question is, okay, well, what does stopping mean for you? What would that look like? What would success be for you? Because I can't a priori sort of assign what success would look like for a person. What we didn't see in those clinics was people coming in and saying, I'm using LSD in a way I don't want to, and I'd like help stopping. Often the only real directive suggestion you offer when someone comes in for opioid treatment and says, I'd like to stop using opioids, you say, okay, we can help you do that. Do you smoke? I go, yeah, but can we deal with that later? Like, let me stop using heroin, then fentanyl. That transition happened while we had those clinics. So we went from seeing a lot of heroin metabolites in urine samples to seeing almost no heroin and all fentanyl, which was such an interesting transition. But You'd sort of say, well, okay, but you came here trying to stop opioids. And I said, I'd help you with that. So we figured out what that looks like. Let's do that. But also, would you consider not smoking? Because that'll kill you.
You're listening to Ordinary Unhappiness, a podcast about psychoanalysis, politics, pop culture, and the ways we suffer now. I'm Abby Kluchin.
I'm Patrick Blanchfield.
And today I am so pleased to introduce Dr. Dan Karlin. Dan is the Chief Medical Officer at MindMed. He is a psychiatrist, also trained in addiction medicine and clinical informatics. Dan's professional life has been in the pharmaceutical, biotech, and medical technology industries, working on psychiatric drug development, novel measurement instruments, and strategies for advancing clinical research methods, and in clinical psychiatry and addiction medicine. Dan trained in psychiatry at Tufts, where he continues to hold a faculty appointment and teach psychiatry residents. He attended the University of Colorado School of Medicine and Columbia University, where he completed an MA in clinical informatics and cognitive science and undergraduate studies in neuroscience and behavior. Dan, welcome to Ordinary Unhappiness. We are so excited to talk with you today.
Yeah, I've really been looking forward to this conversation. It's great to see you.
So can you tell us a little bit about your background and about how you came to be interested in and involved in psychedelic research?
Not on purpose is the easy answer. This was not something that I'd planned, that I anticipated. Psychiatry, on the other hand, was something that I can't really remember a time in my life when I wasn't interested in psychiatry. I grew up in a household that was about as neuroscience-y, neurobiology as one could. My dad had discovered the structure of the acetylcholine receptor before I was born. And so the idea that mechanisms of the brain were tractable and knowable was something that he was deeply invested in. But I also encountered Freud on his bookshelves. And I think he saw what I continue to see in the world, which is that the brain is complex enough that it will never be able to be interrogated from just one direction. That neurobiology and psychology don't meet in the middle, and they might not meet in the middle, so that we need these different systems of modeling what a brain does in order to have any hope of meaningfully understanding ourselves in reality. So always interested in psychiatry, went to medical school with the intention of being a psychiatrist, and had been right out of training recruited to Pfizer to work on a computational neuromedicine group. The thought there was, could we model receptor systems in a way that might enable some sort of novel target seeking, novel identification of places to try to send drugs in the brain? And what we figured out really quickly as this group emerged was that it's something that the drug development enterprise was already pretty good at, in as much as you can be good at it with what we lack in mechanistic understanding of psychiatric illness. And what we became, in essence, was a measurement group, looking at ways of trying to find signals that drugs were doing things that we wanted them to do, that were finer grained, both in temporal resolution and in their ability to detect signals, like low amplitude signals. And that ultimately, when I left Pfizer left psychiatry, and I left Pfizer not too long after, though had stuck around long enough to do measurement across other therapeutic areas. And when I left Pfizer, I worked on digital medicine projects, a nonprofit called the Digital Medicine Society, but a couple of for-profit startups oriented toward treating using digital technology and measuring with digital technology. So that led to the creation of this company, Health Mode, which was acquired just about 5 years ago, which is what put me in the MindMed job. I'd been watching from the outside, I think, like a lot of other people, with great interest, but no real personal investment. And I wasn't really looking for this when it happened, but the opportunity was awesome. And I can't imagine a seat I'd rather be in psychiatry than the one I've been able to sit in for the last 5 or so years.
That's remarkable.
Yeah, I just want to flag up front my capacity to think quantitatively is close to nil, and that's about as close as I can get to numbers right there, right? But I was just I just had this intensive experience teaching a bunch of people Freud's analysis terminable and interminable, right? And that's what one of the several things that struck me about that text that I'm appreciating anew listening to you, and that's deepening how I'm appreciating what you're saying, is this fact that even like 80 odd years, he's 81, right? He's at the end of his life. He's like, well, there's this quantitative dimension that we know is there. And also there's a qualitative dimension. And I could make some sort of crude estimations based upon how people present qualitatively that there must be some sort of difference in degree that becomes a difference in kind quantitatively. But also I can't deterministically like tell you what quantitative yields what qualitative output, and toggling between these two modes of thinking is itself mystifying and perhaps an eternal challenge.
This is, I think, exactly what developing drugs for psychiatry exposes, which is that you can point to these two models. I mean, I often have to kind of remind people that we're not dualists because we have these two completely different languages for describing the same thing. And so when we find ourselves talking about, well, the psychological mechanism or the neurobiological mechanism, like, okay, but also they're the same thing. We just have two completely different ways of understanding them. But we do tend to think that it all is contained in the substance of the brain. And so in the development of drugs for psychiatry, you have to contend with the fact that you're trying to change psychology through something that is well, not entirely because we have the placebo effect, but largely neurobiological. And you can't, the fact that the models don't match ends up being something that you can't avoid by talking around it. Either you can measure a psychological change from the neurobiology you changed with a drug, or you can't.
So you're the chief medical officer at MindMed. Our listeners are going to want to hear a little bit about that. What is the company's history and mission? And what can you tell us about the clinical trials that MindMed is conducting and its therapeutic goals?
Yeah. So MindMed was created pretty specifically for the purpose of bringing certain drugs that had been left out of the scientific conversation for the past 50-ish years to bear on brain health disorders. And there were a few drugs that the company started with, one of which is more or less not in development, but the other one was LSD. And so from the outset, the founders of the company, of which I wasn't one, I was brought in by the founders through that acquisition of Health Mode, but LSD was a drug that they recognized had shown this tremendous clinical potential in the early days of research on the category. And in fact, the discovery of LSD opened the door to a lot of the psychedelic research that was happening at the time. The Western interest in the category seemed to be spurred by the power of this remarkably potent molecule. And as on your previous episode, which provided a far more comprehensive and reliable history of the cross-category research than I could do. But what we saw was in that research evidence for efficacy across a wide range of conditions that, of course, were called different things then than they are now. And the quality of the clinical research probably not to the standard of what we would hope for today, certainly not from a regulatory perspective. But recognizing that there was this space, and you think 5-6 years ago, there's enormous hype in the space, and the company recognized, the people starting the company recognized that there wasn't very much attention being paid to LSD, probably in part because the academic researchers who were able to take these things off the shelf and start doing research with them again, just had an easier time going to department chairs and saying psilocybin than LSD. Mm. And so there was all this attention on psilocybin, largely because that's what people like Roland Griffiths and others picked when they started doing this research. And so recognizing LSD's potential and the fact that it was seemingly overlooked in that space opened up the possibility to move forward pretty confidently toward selecting a therapeutic area. Our first therapeutic area, our first target is generalized anxiety disorder, which, given your interest in the history and the origins of psychiatry, I mean, it's not lost on many of us that anxiety disorders were of primary interest for, at least on the neurotic side of the equation, for psychiatry. And it's only the last 30, 35 years that we saw this strange elevation of MDD into this sort of real disorder. I mean, I remember, I think we're all about the same age-ish, but I remember growing up and the TV told me that, well, Pfizer via the TV told me that everybody worries, but major depressive disorder means you have a chemical imbalance in your brain, right? And of course, the chemical imbalance was a Zoloft deficiency.
I remember those ads. Yes,
Yeah.
that particular SSRIs are going to save us all moment
from everything, right?
Yeah.
And the SRIs. Well, there are a bunch of things to say about the relationship between GAD and MDD and SRIs as a drug class. But for a number of reasons, the companies developing SRIs found it easier to develop them for depressive disorders, and depressive disorders, which by their nature are cyclical, also periodically go away regardless of if the drug works. And SRIs don't work particularly well against anxiety cluster symptoms in many people, and often early in treatment exacerbate anxiety. So you're giving somebody something that takes a while to work, can have intolerable for some side effects, and makes their primary complaint worse for a while. It's not a great thing. So it's kind of evident why MDD would be pushed by the industry, but psychiatry, not necessarily to its credit, went right along with it.
I would think also, and I don't have Patrick's issues with math, but it does,
Thank God,
read. I did read some of the papers that you sent along, and I spent some time on Google Scholar, and I can get most of it. There's some of it that eludes me, but here's my, as a humanist, I'm not doing math, I'm counting, is LSD lasts a lot longer than psilocybin. I would think that would, am I wrong to think that would have played some sort of role? And especially looking over the materials from MindMed about the phase 2 trials and what a day looks like. It looks like you're making something that is shorter acting.
Great question. And some of the math eludes me as well. We get specialized people to do the harder math because it gets tricky. But the number of hours someone is in a clinic is something that I can contend with mathematically. Yeah. And so for phase 2, we didn't have experience giving people this drug. MM120 is what we call our pharmaceutical version of LSD. We didn't have experience with that going into the phase 2. And because the phase 2 was a dose range finding study that had doses up to 200 micrograms, we gave people 25, 50, 100, and 200. And we didn't know what to expect. We came in with some of the same baggage that people accompany that drug with all the time, which is, are we going to see bad trips? Are people going to be having sort of meltdowns in the clinic? We had 2 dosing session monitors in the room with each patient, one of whom had to have some sort of a clinical license, not necessarily a psychiatry, psychology license, but some sort of license to practice in the state. And we didn't know how long it would last. There was a lot we didn't know. So in the phase 2, we agreed with FDA that we would keep people in the clinic for 12 hours.
Okay.
And starting at hour 8, in order to start to build this body of evidence, we used effectively a symptom checklist that we pulled from the DSM-5 criteria for so-called hallucinogen intoxication. I don't even say hallucinogen anymore. I've come to believe these are not hallucinogenic substances, and we can talk about what that means to me in a bit. And so we were really looking for full resolution of drug effects. Now, if people are going to get better, I guess that means there can't be full resolution drug effects because they're supposed to leave the room different than they went in, but at least that they weren't having these transient affective, cognitive, and perceptual changes. And based on the evidence we were able to gather, through that checklist, starting 8 hours after administration, even though we kept people for the full 12. In phase 3, we're now down to an 8-hour minimum monitoring period. And we have a much more refined checklist that, instead of looking at just having any experience of the drug, looks at things that might affect safety. Are people alert and oriented? Are they able to walk or move however they came into the room to get out of the room? Are they oriented to reality? And we start doing that at hour 5. So in the case of our current development program, where we are just bringing forward 100 micrograms as the treatment dose, what we hope to do is come out of phase 3 with a much better sense of when people are safe to leave after taking the drug. We expect it'll be somewhere between 5 and 8 hours for most people, which means it's not a whole lot longer than your average sort of dose equivalent psilocybin dose, though no one has really done the same sort of dose range finding in the psilocybin world. They've just gone forward with some of the doses that were picked. I wouldn't say arbitrarily isn't exactly right, but were picked for historical reasons more than evidentiary ones.
A question that's both numerical and hopefully not too like crudely put. So these are microgram level doses. You mentioned 25, like was it 150 or so?
Yeah, we use the 2 higher doses in phase 2 were 100 and 200. Yeah.
Mm-hmm.
For listeners whose understanding of this or a familiarity with LSD may either be just simply historical accounts or various interactions with illicit and unregulated markets. What I don't even know how to phrase this question properly. Like,
you mean like
a
what
tab?
is in a tab?
Is this like a blotter?
Yeah.
Like what exactly is this in terms of what a person might be encountering as a dose in other settings, either at a music festival or I don't know, when they're reading a John Cheever novel or watching Mad Men, maybe. I don't know.
So the specific dose levels we picked, and these are all freebase equivalent. One difference is this is reliably very high quality drug.
Yeah.
And the dose is knowable and known. 25 micrograms is at the edge of perceptual effects. So people start to reliably be able to feel something at 25.
Mm-hmm.
50 is sort of in the mid-grade of perceptual effects. And at 100, what people describe as the positive effects kind of saturate, and you're not getting more of those good feeling effects as you go up to 200, but you do get some more off-target, less pleasant, even acutely anxiety-inducing. At 200, we also saw more gastrointestinal distress, so people can have some nausea, and even at 200, and a tiny bit at 100, some vomiting. In phase 2, we used capsules, so it's a powder and capsule formulation. We do what's called a bioequivalent study, so you look at the pharmacokinetics, the amount of drug circulating in the blood of one formulation versus another. And we transitioned to an oral disintegrating tablet for phase 3. So that dissolves more quickly. It gets people up into that effective dose concentration more quickly. And it mitigates some of that gastrointestinal stuff that people are feeling. But we're not bringing 200 forward anyway. We really pretty reliably saw that the treatment effects at 100 maximize, and that people didn't get better outcomes with 200. And in fact, it took a little longer to see the treatment effect at 200. We can only postulate about why, but 100 clearly emerged as the right dose to bring forward into phase 3 and ultimately into the clinic if it's approved.
Can I ask you about that distinction between the word psychedelic and the word hallucinogen, and why you're not interested in using the latter these days?
Yeah, this is another thing that has been incredibly interesting to be up close to this research. And I'm increasingly convinced that, and this is an interesting place where the neurobiology and the phenomenology align, which is that what seems to happen in that period of time where people are having those transient effects is a disorganization. So this comes to and sort of brings up one of the most interesting through lines, I think, in psychiatry and psychology, which is, if you think about personality formation and all of this stuff that makes us who we are, it turns sort of a genetic substrate into the person we become. And you think about the time period where basically all of the analysts point to these things happening. The thing that is happening during that period is the organizing principles of the world are getting encoded. And so this has always been a really interesting intersection of this neurobiological ways of looking at the brain and the formation of a psychology, which is that the way that our brain operates in the background when we're not using it, right? When we're not purposefully using it, seems to just be filtering and organization. It turns this incredibly complex set of perceptual stimuli that are both originating outside of the self and inside of the self, turns affective stimuli that are coming up from parts of the brain that we don't have direct linguistic access to. Call that the unconscious if you want sometimes. Emotional stimuli, cognitive stimuli, all of the things that we are sort of bombarded with as we go through life, and turns them into sense and order. That same thing that's happening in the brain in the background, in the so-called background, I don't know, you can really turn it off, but could be called from a neurobiological standpoint the default mode network, right? It's what the brain is doing in the background. And so when we look at people acutely under the influence of this category we call psychedelics, that organizing system seems to be turned down or off. And so the perceptual thing that was described as hallucination doesn't really align with how we think about hallucination from a psychiatric sense, where it's the existence of de novo things in the world that are believed to be real, right? So someone who has auditory hallucinations hears voices that they believe are real voices originating from outside of the self. What people describe in and after these sessions is more the sense, first of all, the main word people use is ineffable, right? So the first thing people say when they're asked to describe it is, I can't. Right. There are no words for that. But
kind
that,
of a nightmare for a research scientist.
Certainly if you're trying to capture the phenomenology and the first word you come up with is, well, they couldn't describe it. But I think that's because the thing that is being turned down or off has a lot to do with linguistic encoding, right? And this is, of course, like when we think about conscious, unconscious, the conscious brain's the brain that you use to do this thing we're doing now. It generates the language that we use to talk to each other and the language that we use to describe ourselves to ourselves. Like that story we tell ourselves about us, which arguably is pretty closely connected to the ego. What's the other description we get from people who've had a pretty intense psychedelic experience is ego dissolution, right? Yeah. The ability to tell myself my own story went away. And so that loss of filtering, there's the perceptual stuff, there's the visual and auditory and synesthesia, crossover sense and all that. But I think that's all deeply connected to the disintegration of the organizing systems.
This is absolutely fascinating. And I'm finding myself really stimulated in a variety of directions by the vocabulary that you're using and sort of the picture that you're painting. And if I could just try to reframe it back to you and tell me if this makes some degree of sense in light of what you're saying, and possibly to use phenomenological language in particular, because that may be very helpful. To call something hallucinogenic is to kind of smuggle in what seems to be an ontology, right? There is a real world out there that you are failing to perceive properly because of this substance that is producing fictitious entities. So the subject is disrupted, fake objects are created. What I take you to be saying as a better way of thinking about what this substance does particularly is to kind of sidestep that question of ontology entirely and to look at how, well, let's call it the subject is continuously being produced, but also kind of getting concretized or stuck in this kind of creation of, again, I'm trying to bracket ontology while doing this, but like the Umwelt or like the person or hell, the psyche itself is an output of, let's call it like psychogenic processes that a psychedelic interrupts or kind of does something radical to sort of suspend or to take apart. And the closest analogy I can think about this, and perhaps in terms of how to put that in terms of like phenomenological terms that also bear on therapeutic efficacy, because I think this is much more radical in some ways, is how when, and I'll just speak from experience, but also other people I know and what I understand of the literature, when they've taken, let's say, SSRIs or some that oftentimes the experience of growth, healing, whatever it is, like of psychic change, if we want to use it in those terms, is an experience of a differential, right? Like some sort of stressor, you have a brief moment of pause before you have the panic attack, right? Or you have some degree of additional kind of perspectival shift. And obviously that
things are at a distance.
Yeah.
Yeah.
And generally that happens when you change dose or you have to change. It's a narrow window where a little bit of things change and other things may or may not change with it. But the psychedelics, as you're describing here, seem to be intervening on a much more radical level of psychic organization and potentiating sort of new possibilities or just allowing something to reflect on itself. Does that track?
I think that's extraordinarily well put. And it touches, and Abby, what you said touches well on what traditional psychiatry drugs do, which is distance, right? They suppress. Benzodiazepines suppress.
Yeah.
SRIs even suppress. And, I always want to be so careful when I talk about what's available today, because first of all, I'm someone who at times prescribes them, though not currently. My current practice is a very, very limited psychotherapy practice. But those drugs have clearly helped people who felt really, really badly. And if the thing you feel is mostly bad, suppression, great. Like if you feel a little less bad and bad is what you mostly feel, that's excellent. And I never want to say anything that would discourage someone from getting care today, because what's not available today outside of research use are the sorts of drugs I work on. But they are suppressive. And even something like a psychostimulant, which this is such an interesting one, which it literally has stimulant in the name. But what it actually seems to do is allow for the suppression of extraneous perception and distraction from extraneous stimuli. It actually is suppressive in a really interesting way. And so what MM120 and other psychedelics seem to do in the clinic is not that at all. And of course, some of that you sort of have to recognize, because unlike every other drug in psychiatry, which you take and while the drug is on board, you feel in some way different and hopefully better. In our case, we're talking about a single session in phase 2 that led to remarkably measurable change, even as much as 12 weeks later. So that the thing that happens while those transient effects are at play and whatever follows, psychologically or neurobiologically, but of course both in a certain way, has to represent an actual change.
Yeah.
Because the drug's long gone.
This is just a logistical question, but am I correct in assuming that anybody who's involved in one of these trials for generalized anxiety disorder, for major depressive disorder, what have you, many folks would be taking something like an SSRI, benzodiazepines, what have you, and before they enter the trials would need to completely taper off of those medications. Is that right?
Yeah, we made the choice to develop MM120 as a monotherapy.
Okay.
As many psychiatry drugs have been in the past, that obviously hasn't prevented excessive polypharmacy. Psychiatrists are not afraid of co-prescribing drugs, but we thought it was important to establish efficacy in as stripped back and drug alone of a paradigm as possible, which includes, and this obviously is something that we can get into now or in a bit, but this idea of psychedelic assisted therapy and what that means and how we've tried, again, not out of any disregard for the strength and power of psychotherapies. I continue to believe psychotherapy is the only curative treatment in psychiatry we have available to us. But it's because of that regard for psychotherapy that we try to study the drug with as little of a dyadic or interpersonal interventional component as possible.
You know, I mean, I'm asking about this out of curiosity, but also because I don't want to say withdrawal necessarily, but sometimes withdrawal is what's in play, but also, you know, the removal of that buffer, you know, it seems like a major obstacle to treatment. So I'm wondering how you think about that frequently the people who might need this intervention the most are the ones who would have to do, who would have to undergo a significant amount of psychic suffering to be able. And my understanding also, obviously, I'm a humanist. I'm not a doctor, I'm not a scientist, but also is that serotonin is something that is involved, right? That there are also like good reasons beyond simply wanting to try this as a monotherapy for not wanting patients to mix something like a lot of the forms of antidepressants that are on the market with psychedelics like LSD or psilocybin.
Yeah, let me take three angles on that because it's relevant. And I think there really were three sort of acknowledgments. One is in the research. So the research, we really focus on getting to what's the point of it, right? Are we able to measure something that is a real thing and is most likely to remain a real thing in the real world? And so for the research, taking people off of background medicine seemed to be really important, because otherwise you start to create a whole mess of different combinatorics of who's on what and for how long. And in the research, though, people only come to these studies if they feel crappy. I mean, we set our enrollment criteria right in the middle of the moderate category on the scale we use to measure anxiety, and people are coming in for screening often on background meds, still hitting that threshold. So we're not asking people who are doing well on their current meds to come taper off. That isn't how we would want to operate. And those aren't the patients who are most likely to end up being treated with this drug if it's approved. So for the research, felt pretty comfortable with that. We, in most cases, didn't see people doing a lot worse coming off of those meds. In many cases, they'd been on something for a long time. It had the effects, good and bad, that it had. The opportunity to try something new that might be meaningfully better, even at the risk of not getting an effective dose, because, of course, you enroll in one of these phase 2 study sites. You got what you got in the randomization, and that was it. In phase 3, I feel even more comfortable tapering people off of their background meds because we have an extension phase after the 12-week double blind, where if people are still moderately sick or worse, they can get open label treatment. And we set it up so they can get up to 4 open label treatments. So we really want to understand the dynamics of open label, more real world treatment in that study. And that makes tapering people off of their background meds just that much more comfortable. In the real world, we think people will probably have some restrictions on when they can get at least payer-supported treatment, which will require having been failed by some number of earlier meds. Usually it's 2. For those folks, we would like to be able to bring forward a body of evidence that the dosing session, the dose of MM120, can be given even with someone on a standard SRI or other background med. And so the optimal order of events is not come off your med, then get the treatment that might put you in remission.
Right.
Obviously, ideally, we do that in the other direction.
So I want to get very much into some questions about what if we want to use sort of more psychedelic colloquialisms we might call set and setting. But first, just a little bit, we've been talking about generalized anxiety disorder and major depressive disorder because these clinical trials are specifically aimed at treating them. But I was hoping before we get into like what a dose day looks like in these trials, you could speak to the prevalence of these conditions today, as well as their comorbidities and the reasons why current standard treatments, in your view, fall short, whether chemically or otherwise.
Yeah. So GAD and MDD are really interesting, and we talked a little bit and can continue to talk about why one might be diagnosed over the other. There hasn't been a new medicine approved for GAD since 2007. And so in a world where psychiatric diagnosis is often as oriented toward operations as it is toward some sort of epistemic like truth or a description of the real world, obviously, MDD diagnoses are going to be made when getting access to any of the newer medicines requires someone to have MDD. I increasingly have started to think of the two of them, GAD and MDD, that is, as not being nearly as separable as maybe we would have thought historically. From a regulatory standpoint, we have to have pretty recognizable populations of one or the other in the studies. But the real world experience of these two disorders is that, first of all, there's about an 80% construct overlap. So if you just draw lines between the definitional constructs in the DSM, you can kind of make up about an 80% construct overlap, which means that, of course, they're incredibly highly comorbid. Of course, it raises some questions about the ontological meaningfulness of the categories, but well, maybe I'll actually do that. So what I think happens is we know that when people are accurately and well diagnosed, there's a lot more GAD in the population than is diagnosed. So if you do population level clinician assessments, essentially you do a full psychiatric structured assessment on folks in the population, there are about 50% more people with GAD than have a GAD diagnosis. That's because GAD is pretty much a constitutive background experience. And as you might imagine, folks with GAD, if they end up in treatment for it, or when they end up in treatment for it, it's because something has made it intolerable. Something's made it so bad that they think they need help. But usually they've got a pretty nice set of intellectual defenses to protect the anxiety, right? Look at how scary the world is. Why wouldn't I be anxious? Look at this little slot machine I have to carry around in my pocket all the time that usually just brings bad news. Like, yes, why wouldn't I be? It would be weird if I weren't anxious. MDD tends to emerge from those same folks, but it's a real state change, right? So that if you know you could get out of bed and go to work yesterday, but today you just can't, well, that's going to spur people to get treatment. And it's a lot harder to say, well, I'm supposed to be this way. I'm supposed to feel this way. So I have much more come to the belief that there are edge cases. There are people who just have periodic depressive episodes that define this disease as MDD. And there are people who are anxious, but have not had and will not have a major depressive episode. But those are the rarer cases, and that most people live somewhere on the I'm anxious at baseline, and then I have periodic breakthroughs of major depressive episodes. The prevalence of diagnosed disease, 20 to 30 million people with GAD, 40 to 50 with MDD in today's world, in this sort of operational diagnostic world we live in today. Probably many more walking around undiagnosed. Like I said, probably more GAD than MDD in that case. The reality, though, for these folks who have more than ordinary anxiety, let's say, the effects can be quite debilitating for family life, for people's own sense of satisfaction, for their ability to accomplish goals they set for themselves. Really, really difficult for folks who are just constantly worried. And the nature of the thing is that it's the worry seems to be free floating and just attach itself to whatever happens to present. So it's not worry about a specific thing. It's the thing du jour, whatever the worry can attach to. MDD, of course, I don't need to emphasize there how incredibly destructive depressive episodes can be for people. And so the combination of the two, increasingly recognizing that the combination of the two are often probably people's experience, that even if you manage to tamp down a major depressive episode with, say, an SRI, what's probably left in the background is a lot of anxiety. And the current treatments, just don't do that much for that many people and bring weight gain and gastrointestinal side effects. And of course, the sexual side effects, which when you actually look at why people, 50% of people discontinue SRIs, it's like, well, you felt really crappy. Oh, and now you either can't have or aren't interested in having sex. Feel better. This is like the additive effects of the downside, and the not super reliable or high magnitude positive effects can really be tricky. Benzodiazepines are the other big anxiety medicine. looking at the course of drug development is always so interesting because, of course, you look behind benzodiazepines, you've got barbiturates. Barbiturates, of course, incredibly dangerous in overdose and in combination with alcohol, deadly, quite frankly. So benzodiazepines were this like great new safe barbiturate. Of course, 30 years of experience later, 40 years of experience later, they don't look nearly as safe, and they're dangerous in withdrawal. They certainly, in as much as drug dependence is the thing when you're prescribed drugs, they often require dose escalation and things like this. There's some clear cognitive effects, and increasingly they're being implicated. Long-term use is being implicated in the development of dementias. So not a great option there either. Particularly for the anxiety disorders. SRIs have more evidence in depressive disorders. The newer ones, of course, only have labels for MDD. So while there are treatments, the options aren't great.
So let's, with all of that in the background, talk about what the protocol looks like in the clinical trials that you've been doing with MM120. And so the last time that Patrick and I did an episode on psychedelics, we were talking to Dr. Josh West in Melbourne about this 3-day long protocol. Like it was quite elaborate. And this is in the context of psilocybin assisted therapy. There were 2 therapists in their room at all times. There's 1 day to set ground rules, a dose day, and then a day of integration. And it was all back to back. So it was 3 straight days. And the way that Josh described this also is, the effect on the clinicians. This was unbelievably rewarding, but draining, right? It's a very elaborate protocol. And I'm bringing it up here partly because our listeners will be familiar with it, but also because the distinction with what you all are doing seems quite striking to me. MindMed's working with this model that removes the explicitly psychotherapeutic dimension and condenses the experience to a single day. And so if I understood the materials that I was looking at correctly, there's what you call a dosing session monitor, who is a clinician who's present both for safety reasons and logistical reasons. There's nothing that looks like what listeners might imagine as a therapeutic encounter. And that's a very deliberate choice. So I'm hoping you could tell us about the reasons behind this structure.
Yeah. First of all, that episode was awesome. And I think it's just so important to say and re-say again that this is not a position that we're taking on the usefulness of psychotherapy, either outside of psychedelics or alongside psychedelics. I can't say that enough. That this is not a philosophical orientation towards psychotherapy. It is a orientation toward science and toward what needs to happen for regulatory approvals and for what will enable the broadest swath of clinicians to use our drug as a tool in their toolkit to help people and reduce their suffering. So this is not me saying that psychedelic assisted therapy, whatever that means to you, because it means a lot of different things to a lot of different people, isn't a valuable interventional paradigm. What has happened in my life since becoming a part of this paradigm and promulgating information about it is you would not believe how much people want to talk about what is and isn't psychotherapy. That at the edges, it's like, I did not think this would be so unclear. And people make good points. One of the most interesting things that I've come up with is like, yes, some of our dosing session monitors are trained psychotherapists. That is what their clinical licensure is in. It's what their clinical training and orientation is in. We give them very explicit direction that they're taking the day off from being a psychotherapist and they are putting on their generalist clinician hat. People say, well, they must be doing psychotherapy. And I really hope that I can adequately communicate how much being a psychotherapist doesn't mean you're always doing psychotherapy.
Thank goodness.
Right? Yeah, I mean, it would make me more insufferable at dinner parties than I think I probably already am if I was also trying to do like psychotherapy without permission. But and people will point out that some of the same skill sets and even some of the same interpersonal maneuvers, rapport building and mirroring and these sorts of things that can be part of good psychotherapy could be happening. And I think that's true, but like a good waiter does those things as well, and they're not doing psychotherapy.
Right.
So maybe they are. Yeah. but
Yeah.
but the psychotherapy the term has to mean something, or we should stop using it. And to me, it means applying a systematic, theory-based intervention to try to induce change in someone. And I think it has to be that. And so what we very explicitly do is not that. What our DSMs are, what they're told to do, what they're monitored as they do, is they go through informed consent, as we would with any other research drug.
Mm-hmm.
But of course, because our research drug has these peculiar and quite remarkable transient affective and cognitive and perceptual changes, they have to go through that. You may or may not feel the following, right? Because people also get randomized into a placebo group, and
Sure.
they might not feel any of that. Some people feel some degree of it, or more or less than another. So the program of the DSM is do an informed consent.
Dosing session monitor.
Dosing session monitor,
okay.
Yeah. And we've had to, our language has had to evolve as the sort of field chases us a little bit. And so, dosing session monitor was the best descriptor of what we want these folks to do and what we know them to be doing when we talk to them, and when I'll describe the paradigm in a minute for what happens in the room. And part of all this is just to set the DSM up to be able to provide what we've taken to calling assistance and comfort, so that they're in the room activity. And in phase 3, we mostly are doing a single DSM in the room, but there is a secondary DSM watching via essentially closed loop video. So we don't record the sessions for a couple of reasons, but we do have the secondary monitor watching, and that helps with protocol adherence too, adherence to this not doing intervention. But that it was interesting hearing Josh describe, I don't know how much there was for the therapist in those, because mostly what our DSMs do during the day is read a book, because most of what's happening in the room is very internally directed. The patients have eye shades, they've got music that they can listen to, they can pick from playlists, or if they don't like our playlists, because our playlists are pretty benign, quite frankly, they can listen to their own music. They can, they have a Spotify account they can use. And the DSMs monitor for adverse events, because we need to record those for regulatory purposes. They check vitals, because we need to record those for regulatory purposes. And they leave the patient alone as much as possible. Patients will need to go to the bathroom. Sometimes walking can be unsteady. They'll help with that. People get hungry. They can get snacks or order food if the participant wants that. They do the end of session checklist, which is how we decide when someone's safe to leave, even though we're keeping people for the full 8 hours for now. Maybe in the long run, that's not the best model for this. And the closest I think you could say that they come to doing a therapeutic intervention, even though it's not meant to induce change outside of the session, is people do sometimes have some anxiety and need to be reminded that, no, you're not going to be like this forever. And remember, we talked about drugs that you may or may not get. It seems like maybe you got drugs, and this is how we talked about you might feel. And so, do whatever feels most comfortable for you to be able to get through this. And people mostly choose to go back into that largely internal experience. We've gotten feedback from participants in the research that they were glad to be left alone, that they wouldn't have wanted someone doing more questioning or interrogating or sort of interpreting. And in part, I think that has a lot to do with what we talked about before about language organization and the utility of language while folks are in this state, which is lower than it would ordinarily be.
I'm just thinking subjectively about the experience of having pull yourself together, because there is this other to whom you have to account for yourself with, and in contradistinction to that, having a person who is there, so they're kind of distant but containing in this way, not psychotherapy, but there's someone there that if you need help, again, it's not like they're trip sitting you. They're not there's no therapeutic touch, which seems to be one major difference here, but that you can be safely sort of locked into whatever the experience that you're having that's fascinating.
Yeah, it also occurs to me, and I do think that the kind of old school set and setting language is still really helpful. When we were talking to Josh, he was really talking about ways in which those trials that he was involved in were really working on both of those fronts. And this one seems to be like working on the latter. And, at the risk of, stating this in a way that it's just is like obvious and banal, is like the hypothesis is that the drug itself is the mechanism of change, which maybe sounds obvious, but is certainly, I think, not obvious within the context of like the long history of people who do take psychedelics, outside of a clinical context for insight and change.
Set and setting are such interesting concepts, again, because like PAT, like psychedelic assisted therapy, they've grown and evolved and mean so many different things to so many different people, that when I talk about concepts that could be shoehorned into set and setting, just try to use different words that are more specific to the thing I mean.
Yeah.
But yes, the drug is the mechanism, but I am convinced that that mechanism is at least in part the experience of being on the drug. That even without a therapeutic, a secondary therapeutic intervention, the psychology of being on and having been on the drug during the session and having that transient set of changes do contribute to the mechanism. And so if you think about set and setting as concepts, well, people who come into a study like this come in because they're intolerably anxious or depressed and they would like to feel better, right? We don't have to tell them that. That's the whole reason they showed up in the first place. We do these studies in sites that we have, we're very selective in who we work with and the kinds of places they are. And we want the room in which people are laying or sitting to be a comfortable one that's aesthetically pleasant and not overly clinical. So we do attend to those things. And I think the experience that people have when they've entered into a session-based therapy like this, because they're intolerably anxious or intolerably depressed or whatever, I think that going into these sessions with a different intention, with a different reason for being there, does lead to different outcomes. I think if you're not someone who's anxious or don't have clinical anxiety, diagnosable anxiety, and you're just going in for insight, your anxiety might be completely unchanged because that's not where you were. That's not why you were doing it. It's not why you were there. And certainly we see, one of the more interesting things is that people who go into these sessions to change seem to change, right? We saw a 48% clinical remission rate that persisted out to week 12. People who go into psychedelic experiences to ratify their ego seem to get that too. That's been part of the problem in the history of these drugs as medicines.
I'm thinking still, in light of what you just said about that distinction between like the hallucinogenic and the psychedelic, right? And how that kind of implicates our notion of the subject as this psyche that is continually producing, I guess, like its imagination of itself or some sort of something that is what I'm trying to get at it, I guess, is that when a person shows up, they're kind of bringing the set and setting with them already.
Well, they're bringing the set.
Yeah, but also like if their world is one that's suffused by generalized anxiety, right? I mean, obviously, I suppose doing it in a haunted house versus on a nice couch in a pleasantly lit room, yes, setting does matter there, but also there is some sense in which the person as the site of their own experience, which they are bringing into the world with them and which they're trying to kind of reconfigure, it's sort of always already there. And at the point at which then you have this incredibly powerful chemical doing something to them, there is, and this is also, I think, very fascinating, something about their conscious subjective and also like subject object dualism conditioned intentionality interfaces with the substance to produce some sort of change. And both the open-endedness of that, but also the apparent directedness of it is really something. And I'm thinking here too of the episode we did with Sarah Miller about her experiences going to do ayahuasca in Peru, and how that, there was so much of that was about building the expectation and then having this experience, and there's a drumming and there's a shaman and all this, but then part of the experience is just like, well, this isn't what I bargained for, or some sort of disjunct between the elaborate context and the actual event itself. Whereas here there seems to be, almost precisely because the therapeutic pretense is bracketed in this way, something else happens, or it's somehow straightforward isn't the right word for this, but somehow there's something imminent there, if you will.
I mean, her storytelling in that episode was so evocative and interesting, and yeah, it's like if too much is promised from the shaman patient dyad or the group whatever process that's happening, or the importance of the music, and you just find the music's not that interesting and not working for you or whatever, that I think all of that sets up the risk that the focus isn't on that subjective experience, the desire for change, the desire to feel differently afterward. And I think we've sort of done the same thing by de-escalating the therapeutic role of the person in the room. They weren't going to do a whole lot anyway, right? So they can't disappoint. It can't become, they can't, I mean, you say can't about transference, you forget that it feels just real feelings, but that you're less likely to end up with the focus being on some transferential thing that's happening, and that all of what, as exactly as you say, all of what the participant in the trials and the patients in the real world, if we get there, bring in, gets to be sort of unmitigated by the incidentals of what exactly the clinic looks like, or what's on the playlist, or who the DSM happens to be, and what their orientation is, and all these sorts of things that come into play in regular therapeutic interactions, where the therapeutic agent is either the therapist themselves, or something that sits between the patient and the therapist.
I'm going to revise my previous, the drug is the mechanism, to go back to the sort of idea of the experience is the mechanism. And again, I'm really painting with a very, very broad brush here, but I want to revisit that in order to ask you what you can tell us about the qualitative experiences that are being reported by participants in MindMed's clinical trials. How do patients, and I know we're going to get to talk more about ineffability, but how do patients describe their experiences both in the moment and afterwards?
That's an excellent question. And you just, in even asking the question, ran into this sort of accidental dualism that I feel like we're constantly having to talk about. Like, okay, if the experience is the mechanism, is that neurobiological, or we know it's induced by a neurobiological thing? I mean, we're constantly hearing about neuroplasticity as the consequence of taking these drugs. And my reaction to that these days is like, well, I hope so, because we know that people are feeling really different, and there's no more drug in their brain. So if it's not through a change in the brain, where did it happen? So it's like neuroplasticity as the cause of and the evidence of, and there's no ability to ascertain directionality. I mean, this is like the problem of neurobiological causality, right? The experience is, it's very internally directed. They tend to have descriptors of body changes, and the sort of through line is relationship to the world kind of changes, which often are interspersed. People will describe, we had a woman who is a psychotherapist herself, who, as a trial participant, agreed to, was long after the trial, but because of her background and because she had a relationship with the site, that they felt comfortable asking this in a way that didn't feel like it was in any way going to sort of induce her to do something that she wouldn't want to do or wouldn't be good for her. She came to an all staff meeting And I interviewed her in front of our whole company on Zoom, of course, because I've never been in front of the whole company. And she described her body being purple, not looking purple, or it just was purple. And her deep, anxious sense of need to be perfect and need to exceed and never having done enough, this very hard driven person, sort of fading away and being replaced with a calmness about just being in the world in a different way. And the parallels here, I mean, in psychotherapy, when we encounter what might be called repression, it's almost never, in my experience and in what I've read, it's almost never, here's a de novo, whole new thing I just remembered that was put away and it's, oh my God, I can't believe this thing happened to me. Instead, it's a new angle. It's a new story around the memory. And this very much had that feeling, which is, I had to do all of this because reasons. Oh, I realized, no, I don't actually have to do any of this if it's not bringing me happiness. And so the change seemed like a very accelerated version of what you get with good dynamic therapy. That there was a retelling of the story around some causal thing from earlier in life that led to some belief about the world, and that belief was being sustained by the story. And then the story could be retold in a way that either changed the precedent, changed that causal thing, or that changed the current relationship to the causal thing.
I'm curious about how that sort of manifests, I guess, diachronically within the experience, and then how that's sort of retroactively narrated in some ways. And as a counterpoint or an example of that might stand in contradistinction to this, I think about how, in psychotherapy, very famously, you can tell someone something that seems to be true and like, oh yeah, that's absolutely true. Thank you so much. That's absolutely correct. I wish it made a fucking difference for how I feel. And that sort of capacity to intellectualize, which, as you've already said, is also present in how, I don't know, like tons of millions of people can accommodate the daily stressors of life in our hell world without realizing that they have GAD or without succumbing to it. It's an impressive thing. And here, however, I'm wondering about, and again, this is ineffable, so it's so hard to talk about, how that sort of telling or untelling or retelling of the thing that is the self relates to like the dissolution of the self in that moment, right? And I think, again, trying to supply other vocabulary here and run these by you, I wonder if there is an element of sort of a distance to this type of thing where like, wow, these symptoms that were me or that I thought were defining of who I am, they can actually be separated from me, right? And just there's this kind of immediate, as subject-object dualism collapses, suddenly these aspects of your own self somehow become contingent. Or is it like a weeping, crying, breaking through realization that's more affectively kind of saturated? Or is I'm just thinking these are, again, perhaps false binaries, but I just wonder how that all shakes out.
Me too, to be fair. we see both of those. We see both of this sort of calm, dissolved, no real story. Why was that the story in the first place? The more sort of cognitive, almost restructuring. We also see emotional outflow, like strong affective outflows. Often people are switching back and forth between the two, which is interesting. We are not doing a lot of interrogation of the real-time experience, in part to just let the experience happen. And also, we're already being told we're probably accidentally doing therapy. So if we started interrogating the experience a lot, we'd be closer to doing something that might be might actually constitute therapy, because there's no way to ask that question without having some setup, something you're trying to elicit potentially, even if that's very neutrally. So I so often, right, we want things to be binaries. And even in this space right now, we're hearing a lot about psychedelics, which I don't know what that really means. I guess it means it touches the same receptor systems, but so do SRIs. So people want it to be, oh, it's the long-term neurobiological downstream signaling, or the session, the stuff that happens in the session, the perceptual changes, the affective changes, the cognitive changes. Those are just unnecessary adverse events, and it's actually whatever else is happening in the brain while those things are happening that matters. Or there are people who very much want to say it's all the experience, and the more you can get just experience without the other stuff, probably the better. I just can't imagine that it would be one or the other of those, or that those would affect the same things in different people in the same way. I mean, I think at the end of the day, if we do give up on being able to establish a directionality of neurobiological causality, which I pretty much have, if we can't even do the direction, then it's going to be really hard to do a fine-grained assignment of what's doing what in whom.
Honestly, as you say that, I find myself realizing that perhaps I'm imposing entirely false expectations of clarity on the mechanisms of action or even the narratability of this experience, when in fact those same ambiguous features inhere in the process of therapy itself, right? And I think you're about the stuff that Abby and I have been reading in the first two volumes of Standard Edition, where it's like, well, linearly, I don't know, when does psychic change seem to happen? It seems non-predictable. Like, I can't tell when this shit takes or when it doesn't, but somehow clearly it does. And it varies for individual people, but also there does seem to be a general sort of trajectory to it, but who knows what's going on in there? And that kind of, the way in which you describe what's happening in these sessions, or these dose monitored intervals, as black box, but also as crystallizing what happens in psychotherapy, or yielding results that are comparable to, an extensive rebuilding of attachment, or any other terms we might be more familiar with to narrate those things.
To narrate psychic change.
Yeah, narrate psychic change in a dyadic context. That just highlights the fact that internality and subjectivity is a black box on some level, and what matters is that it changes.
Yeah. And then that's kind of where we land. Is 35 years into the SRI experience, we still don't know how they work.
Right.
So why are we going to hold this to a higher bar, particularly when it has this profound yet ineffable experiential component built into it? And I hope that people continue to interrogate this via whatever mechanisms they're able to. We have some interesting ideas for looking at how to maybe disintegrate components that might not require changes, that might not require changes to the consciousness, that might be purely neurobiological. But again, how can anything be purely neurobiological? Because if you don't feel it, it didn't work. But I think that's probably right, that we tend to privilege the easily measured and easily understandable over the effective, because it gives us some epistemic certainty, something to hold on to. And while I will do everything I can to try to provide an explanatory framework for potential prescribers, for patients, that is at least a true enough model, that it's useful. At the same time, I do think one of the reasons that there are so many stakeholders in this category, and why these drugs of this sort have held the sway of humans in our consciousness for as long as they probably have, which is probably a really, really long time, is because of exactly that they seem to do something that is truly changing the consciousness of the person who's taking the drug, particularly as you get up into these higher doses. And what I said at the outset was, I think where they're operating, why they're so interesting, is that the same processes and time frame that lays down these filtering mechanisms that they turn down or off is when character and personality and defenses are also being laid down. I mean, the temporality of that is sort of undeniable. And so getting to operate on a brain less constrained by language, and it happens to be your own brain, because it would be hard to deal with someone else's less constrained by language. That's the tool we have to operate on each other's brains, is an experience unlike anything else.
Well, you're cueing me up so beautifully to get us into this conversation that we've teased a couple times already about this idea of ineffability. And, Dan, you and I got a chance before talking today to write back and forth a little bit about this. And I really want to make sure we get into this term ineffability, which, for listeners who have had meaningful psychedelic experiences, which I suspect is a non-trivial percentage of our listenership, I think this term is going to make a certain amount of immediate, visceral sense. And other people might think about it in terms of religious experiences, or if they want to use the word spirituality, they can, you can do that. But, psychedelics produce experiences that are often fundamentally at odds with language, right? That's what Patrick's talking about before, is the narration happens later. For the narration, re-narration happens after the experience is over. And I think it's common enough to be, almost kind of a joke, whether people are talking, and I think this includes cannabis as well as psychedelics, for people to have these deeply meaningful realizations under the influence of these drugs, and they try to put them into words and it falls totally short. Or the next day you're just like, oh, wow, that sounds incredibly banal. And so you'd think, because of this relationship between psychedelics and language, that psychedelics and therapy, given that therapy is so oriented around the production of meaning through language, that they might make kind of uncomfortable bedfellows. But, my sense from our correspondence is that for you, this quality of ineffability is actually a key part of the mechanism of the action of the drug that allows for genuine psychic change, the sort of bypassing of language as the primary way by which we form meaning. So I'd love to hear your thoughts on the sort of idea of ineffability, the state of ineffability, the lack of relation or relationship to language of psychedelic experience, and why that can be, in your view, so generative for treating things like GAD.
This is the William or Wesley Wildman book, Effing the Ineffable, which I haven't read, but
I've got a shirt from my undergraduate in Swarthmore Religious Studies that says Effing the Ineffable.
As far as titles go, it sure F's well. Yeah. I mean, I think what from an almost technical perspective, what we've covered so far today is that acute transient psychedelic experience is to my mind, pretty incompatible with dyadic psychotherapy because of exactly that, because the usual organizing function of language has decreased to a point that it doesn't provide the same tools for putting ideas into each other's heads. And that why the spontaneous language generated in the depth of the heights, I don't know, one direction or the other of a psychedelic session tends not to be meaningful to the listener, right? That it's sort of silly and funny and can be weird seeming, but it doesn't convey meaning in a way that you would ordinarily think of language conveying meaning. And I think that's exactly that. That's the ineffability. I am fascinated by the development of language and how that affects our relationship to the world and to ourselves. And not that, given everything people have said about Cormac McCarthy and things that he very likely did, I'm not going to come out as a huge Cormac McCarthy advocate, but the Kukuli essay that he wrote about the development of language, if not a scientific essay, is extraordinarily descriptive about how language appeared in brains that did pretty well to that point without language, that we didn't need language to get to be phenotypically human. We didn't need language to spend the vast majority of the time we've been phenotypically human as functionally phenotypically human. What we did need language for is, I'm going to gesture sort of wildly out the window I'm looking out of here. And we needed language for all that. And we probably needed language to develop neurotic disorders. I very much have come to this sort of divided brain as being a useful model for understanding both mental health, and I mean the positive version of mental health, not the euphemistic version where we say mental health when we mean something else, but and illness. and that there does seem to be, you encounter psychiatric illness where, as a psychotherapist, you say, not a lot I'm going to be able to do here. I can help someone live with this thing that seems to come up from beneath, from their neurobiological underpinnings. And, psychotic illness certainly has that feeling. Mania very much has that feeling. There are depressions. There's these sort of melancholic depressions that very much just, this is something bubbling up from below, and it's not defenses. It's not a story. It is just a feeling. It could be a somatic feeling for all that I could talk you out of it. I can help you live with it. I can help you, maybe in some cases, accept that it's part of what comes up from underneath in you. And of course, this isn't a binary. Anyone in distress is going to have components that bubble up and components that seem to be about the more neurotic ways that we structure ourselves and our defenses. But there are people you meet and you go, hang on, this experience you're having of the world is something that can get a lot better, if not entirely better, through talking. And that kind of ties back into this thought that, okay, these drugs have a psychological mechanism and a neurobiological mechanism, because I think it is the breadth of those effects, the fact that we have this interruption of language that forces people to experience themselves without that story, with whether the story is filled with defenses or filled with worries about the future or ruminations on the past. That period forced to experience without the story, I think, is a big part of the mechanism for at least some people, if not many people. But that other side of these illnesses, just bad feelings coming up seemingly out of nowhere, also seem to be changed by something that's happening with the drug. Now, trying to think of, again, I stumbled into all these sort of false dualisms. And, of course, there's not one and the other. The two are in constant interplay with each other. But I think that by working specifically on language, we have this remarkable power against the neurotic distress, against the neurotic stories that create distress.
There's so much in what you're saying, and I find myself really just deeply admiring the work you're doing and the ways that you're thinking and talking about it for many reasons. And I trying to follow sort of the terms that we've said here. I find myself rejecting the impulse to, I don't know, adopt like a necessarily compatibilist perspective between like the humanistic and the qualitative and the scientific and the empirical and the quantitative. And it's so hard, I think, for anyone's brain or mind or whatever to wrap around this, particularly once people choose careers or orientations that are, the way that they choose to or find themselves disposed to see the world. But as you say, on the one hand, there are clearly problems in living and experiences people can find themselves in that are not remediable or fixable or even touchable in some extreme cases by simple linguistic intervention. And yet also there are situations in which the right words at the right time from the right person can produce actual change in the world. And being able to think in both terms, or at least being able to acknowledge the existence of both possibilities at the same time, seems so essential, as does not sort of putting unreasonable expectations on explanatory power in either perspective. Because I mean, hell, and not to be too glib about it, but like I have no idea what like the neurobiological mechanism of action is for a successful transference interpretation, right? And I don't think anyone who does any type of talk therapy could, right? And yet when it works, it works. What I'm trying to build to say, though, in terms of the role of language is sort of twofold, and just mirroring back to you what you yourself have been saying, and the way in which language is such a wonderful but also ambivalent tool, in that language seems to, one, give us so much in terms of thinking about cause and effect, right? And structuring cause and effects into narratives of dependable things. So we can tell someone else, well, don't antagonize a saber-toothed tiger, right? Or there's a Gary Larson cartoon, right? This part of the dinosaur is called the Thagomizer because look what it did to Thag, right? Poor Neanderthal. And then there's the way in which language relatedly organizes things into subject and objects. And I mean that in the broadest philosophical sense. I understand that there are different linguistic senses of that. But like the way in which we orient ourselves towards other speaking subjects as particularly salient points of concern and tremendous amounts of stimulus. And both those things, like the orientation of cause and effect and how we relate to subjects and objects, or like just see them distributed in the world, all map out along the axis of time and do seem to build over time with particular intensity in certain developmental windows to become sort of stories we tell about ourselves, and that really do seem to ramify in these examples of like, I don't know, I'm just waiting for the next terrible thing to happen, or I'm waiting for the next depressive thing to happen. And what I take the work of these psychedelic substances to do is rather strikingly to do some stuff in time to our experience of time, to kind of rearrange how we think about cause and effect, right? Like is the wind moving the clouds, or the clouds moving with the wind, et cetera, but also to really do something too. And I think this is very important for the anxiety and depression stuff. It also bears on what the dose session monitor does. Suddenly our orientation towards other people and all they're freighted as potentially being for us or to us doesn't necessarily cash out in the same way. And I don't just mean that other people's like faces are melting, but suddenly you just want to look at this tree for a goddamn hour, right? Or there's something in your distribution of attentional focus, but also of like the agita and the patterns that come with that suddenly gets redistributed. And if you will, since Cormac McCarthy's on the table, I think of that wonderful, also very distressing bit from Blood Meridian, where it's like, you know, if you could see the world as it was and had it not been bled of its strangeness from your having seen it since birth, the experience that we seem to be talking about.
That is a pretty good description of a psychedelic experience.
Yeah, it does something to the blood flow of that.
When so many people who think so much about how we are and who we are, when William James and Cormac McCarthy and Lacan all come to this idea that something is lost when we have to translate the world into language, because we necessarily, the William James example, right? I love his thoughts on measurement and how the tool you use to measure gets you the answer, not the other way around. How long is the coastline of England, right? It depends how long your measuring stick is. And we necessarily coarsen things when we put language to them, and we lose their details. When you learn the word for car, then all cars get flattened into car, unless you become a car person. And then suddenly you get a new finer grained language, not just to describe cars, but to experience, to see cars. And I think this is both the exactly as you described, the joy of language, the expansiveness of language. It allows us to put ideas into each other's heads, sometimes on, as you two have done on a large scale, both in your teaching and through this enterprise. But it also necessarily flattens our experience of the world into the things we have language for. And the expansive potential then is, well, can I get better and more precise and more expansive in truth language through which to experience the world? Because if I don't, on whatever topic this is, I will be flattened by the absence of that better language.
It's almost like the types of subjective distress that we're talking about and calling illness, they're doing something to someone's agency or capacity. And what the angle of approach that you seem to be exploring is one of creating sort of new possibilities for receptivity that also then changed their agency going forward. And I know that all those terms have their own baggage too, but it does seem to be about like a giving back to a person a capacity to have capacities that previously, because of the stories that they tell themselves or the things that have happened to them or what they expect other people or what the world to be like, have been foreclosed.
I think that's perfectly well put, particularly the receptivity part. I so much think of, let's say, neurotic illness, anxiety and depression, whatever this sort of thing we're talking about, to be a, a failure of closeness, of closeness to self and closeness to others. And that's where defenses live. Defenses live at that closeness to self place, right? How can you be close to yourself if your feelings are being filtered through this layer of defenses that lead to or are caused by, right, distressing symptoms? And the defenses are protecting those symptoms because having those symptoms is somehow better than not having them. The question at the outset of therapy is not overtly asked, but that's in my head anyway, is not how do these symptoms hurt you, but what are they protecting? How are they help? What do the symptoms do for you? Not what do they do against you? And true closeness to one's own feelings, to one's own emotional, to one's affective state, emotional state, whatever. Not having that prevents closeness to others. And regaining or gaining maybe for the first time, but getting access to closeness to self then opens the potential, that receptivity you talk about, of closeness to others. And that seems to be a huge part of the change away from being in distress.
If you permit me to ask one more thing or just connect one more pair of dots.
Yeah.
This seems to also inflect how we think about or how we were talking about certain other courses of treatment, and in no way gainsaying triage or the life-saving work done by any of other classes of drugs, but thinking about those in terms of suppression, of suppressing receptivity to stimulus, of suppressing things that are in you or that are in the world or that are traversing both. But in any event, those are things that are, and here I think kind of quintessentially in dynamic terms, right? There's some work that's coming at some kind of cost. You're carrying it into rooms with you. It's preventing you from becoming close or connecting to others. But where this is leading me, and this is, I don't want to put this in too spiritual terms, right? But it seems like the experiences that you're describing and potentiating here, where people are being, not to be too dramatic about it, but kind of cracked open or like allowed to no longer carry that with them, that is not destroying them. And it's also not like the end. There's something almost reassuringly optimistic about that. And I just don't know if, does that track? I don't want to put that on you, but it just seems like that actually seems like, I just feel reassured to know that, because there is this terror, right? If you have these symptoms, if I lose them, what am I going to be?
Who will I be? How will I be?
Yeah.
Which inevitably comes up in dynamic therapies. If not for this thing that sustains me, what will be left? And I think that it absolutely happens in rapid fire in these sessions. With the whole story gone, I continued to exist. So no component of the story is necessary to sustain me. I can exist without it at all and be reconstituted as someone I maybe even more want to be, or in a way I want more to be. And maybe there's an element of fundamentally my traits that I value in myself are intact, but these states these sort of intolerable states that I felt, I don't have to feel anymore, even as I maintain a core of selfness, of existing.
It goes against all of my instincts to like reel us back from the philosophical dimensions of all of this, but I'm going to because I want to shift the conversation a little bit away from qualitative experience to the substance itself, which we haven't talked that much about. But Patrick and I have talked on previous episodes a little bit, especially with Josh West, about the history of LSD, Albert Hoffman's problem child, as he called it in his book from 1979. And, LSD is not only an incredibly powerful substance in its own right, but it has this complex and deeply fraught history in the American context. So, from the 60s counterculture to the military and the CIA's variously gonzo and deeply unethical experiments with it during MK Ultra, to the current hopes for a quote unquote psychedelic renaissance, LSD, to use one of Patrick's favorite words, is this sort of quintessentially overdetermined chemical, for better and for worse. So, what's it like to work with this substance, and how do all of these legacies inform the ways you think about it as a therapeutic tool?
That is a fantastic place to go and really complicated, obviously. I mean, when you had both sides of the culture war of the 60s using this drug, and in many cases claiming they were only using it because the other side somehow forced them to or tricked them into it or whatever. I mean, one, it speaks to the strength of the drug. Just that history, that interest. I'm glad that CIA moved on to other drugs when they discovered that they couldn't induce the kind of suggestibility that they had hoped for with LSD. That workplace seems very strange, where you never knew when your morning coffee might be the one with the LSD, and in some cases, it seems evident that lives were lost.
Yeah.
In and around these projects. It's a shame that we only got to see what we got to see from document releases, because obviously a lot was purposefully lost. The counterculture obviously saw a lot of strength and power in the world as people could see it through the drug. The Controlled Substance Act and the early inclusion of LSD, right off the bat inclusion of LSD, makes you think that the dominant hegemonic systems saw it as a threat. And as does the CIA work, right? That they saw it as a potential threat, and as anything that was a threat was a tool that could be employed. How much of that was in service of other political projects and political aims, it's really hard to disentangle in retrospect. I mentioned before that people who use psychedelics for the purpose of ratifying their ego, and this has been a problem that analysis has observed for a long time, that when you treat someone who's just come into therapy because their fourth awful partner, their fourth awful marriage in as many years as making them, like, okay, well, what do all those marriages have in common? And that starting point for therapy is nearly impossible, because you're likely to accidentally ratify a narcissistic ego in that situation. So we see in the history of the non-medical ego ratifying use of the drug, that sort of emergent narcissistic or at least reinforced narcissism. So there's so much history, again, totally unlike any other drug that we would be working on at this phase in drug development. I mean, it is a drug like no other in that regard. What it all adds up to, though, is we can have interesting conversations about the history. And we try to acknowledge the history as best we're able, as best we can acknowledge a knowable reality when so much is shrouded in secrecy. But I, in a way, I haven't, in other drug development projects I've been a part of, feel an obligation to the drug. It feels like it's somehow embodying its own history. And it has shown so much evidence that it can help people when used in the right way. And we've seen that when it escapes confinement, it also can be put away and not be available to help people. So we and I have approached this through this I think, incredible that it's been 5 years. I cannot wrap my head around the fact that this has been a project that I've been pursuing for the amount of time that I have, because it's gone so quickly in so many ways. But the obligation to the drug, because it seems so evident that if we can do this right and get to an NDA, a submission, and ultimately a drug approval, and the details of that process and that approval and the evidence we've been able to gather enable payer support for treatment in the real world, that it could make not just an enormous difference for individuals who are suffering, but I look at a psychiatry that has lost its way. Anna O didn't label it the talking symptom suppression. That was not psychiatry's obligation. That was not psychiatry's view of its own potential. It was cure in many cases, if not all, because we've talked about this sort of more neurobiological diseases and more neurotic, but a psychiatry that's been captivated by course models that aren't correct and aren't even particularly useful, and has been doing, in many cases, just sort of neurobiological pseudoscience that hasn't helped anyone to feel a whole lot better, while Me Too drugs or minor molecular changes predicated on the same mechanisms that we just happen to discover work, even though we don't even know what the mechanism is really, that's not good, right? We took dynamic therapy away from psychiatrists because the psychiatrists can't make a living doing insurance-supported dynamic therapy. We ended up with I say this cautiously, but let's say the SRI of psychotherapies, which is CBT, because it's easier to deliver and actually because it's easier to study. We focused on the thing that was easier to measure, not the thing that worked better. And so a psychiatry that's been turned into 10 to 15 minute SRI prescribing visits and second generation antipsychotics if the SRIs don't work well enough, while therapy has been taken from helping people to be expansive and live the life they want to live to using your cognition to try to suppress your emotions. I mean, this is not a good state of affairs for psychiatry. It's not entirely psychiatry's fault. Psychiatry has had to live at this intersection of, poverty and suffering induced by a at times really difficult world, and at an individual level, and I think even at a communal level, psychiatry is doing its best in a very difficult situation. But I do see what we're doing as having the potential to help psychiatry refine the potential scope of its mission in the world of why it exists.
I don't envy you the challenges that you're navigating on this, though I'm really glad that you specifically are doing it. Because, and here's another one of those situations where I think we can stipulate a lot of things as being true at once. Like, clearly, the tendencies that encourage certain types of, essentially like an orthopedics of the subject, if we want to use that type of language, get back to work, right? Doesn't matter what you're doing for a living, just do it. Like, or, your symptoms are bothering you. Well, let's not worry about the underlying conditions that produce those symptoms. Let's just make them tolerable again, right? Those tendencies prioritize clear deliverables, monetizability, scalability, and all these other things. By the same token, and this is sort of the other thing to acknowledge, when it comes to any sort of, I think, technology of intervening in the subjective lives of others, and this, I think, applies equally true of talk therapy as it does of any type of medication, but particularly of psychedelics, you can't impose I think it would be a type of fantasy or a folly to assume that this is going to yield some particular output in terms of like a political orientation for anyone involved, right? Like the idea that just because someone goes through therapy, they become a better person, or they're going to vote the way you want them to, is as much a sort of, I think, a fantasy as being just because someone, I don't know. And this is one of those sort of ineffable, like half-baked conversations people have, like, well, we just got all the leaders in the world together and they got high, man, then shit will be fine. Like, clearly that's not how it works. Like the teleology of utopian inevitability goes against, I think, the dispersive and frictional forces that encourage all these types of disconnection and a lack of closeness that you described. So all those things can be true at once. And yet also, and this is, I think, the amazing paradox of the work that you're doing, or at least one of them, and why I'm glad you're doing it, this medication does seem to be extremely efficacious, or holds the promise of being incredibly efficacious. And also, though, it kind of raises the question of what happens once it's scaled.
Yeah.
And here I'm thinking about, I had to go back and do some research digging of this, but I know you're in Chicago, but I was looking up the the statements by like Abby Hoffman and the Yippies, right, in the 68 convention, where they're like, well, we're going to dose Lake Michigan with enough LSD to basically have everyone, tune in, drop out, whatever. I don't have the math, but again, I think you probably need an iceberg the size of like Rhode Island to do that. But the point is, it didn't work. It was just a goofy threat, right? But there is that kind of like, and this is different from every other chemical, I think, or even other drugs that have been legalized or been used for therapeutic potential, like that. There is that kind of utopian possibility freighted with this. That may affect some of the expectations of people going in. What I guess I'm trying to ask is, an actually efficacious psychiatry using this singularly powerful substance would substantively make a lot of people happier and would really seem to shake things up. I don't want to be as crude as to ask you, but like, do you see that happening or like being allowed to happen? And what do you think will happen if it does? And again, I'm not trying to cast you in the Abby Hoffman role here, but just like, if people get less
people can't see,
alienated
but Dan
or
is
more
actually levitating the
disalienated.
Pentagon on
Chicago. This is DC. Yeah. So I think that a couple of concepts there become important, which is that being less distressed and feeling more hopeful about the world certainly doesn't imply being content with the state of the world. And maybe even leads one to believe they have efficacy in the world that they didn't believe before. Whether that has a preordained political alignment or anything else, I think is where that kind of falls apart, because what we see is that people change in sort of in the way they went in to change. And so I don't think that people become more dogmatic as a result of this, unless the dogma is one of these sort of narcissistic projective dogmas of the self, because it clearly reinforces that. But I don't think that our politics have strayed so far from ostensibly their purpose, which is living in a community together, right? If we think about the three pillars that I sort of organize this into, there's science, technology, and society. And they are deeply interactive pillars. So maybe pillar isn't the right word, but things at the level of policy are supposed to be supportive of community and informed by science and apply the best possible technology to the problem it's attempting to solve. And we've drifted so far from using our best technology informed by the best science in a way that maximally benefits society. And so I can't point in a political direction or an option I would have to vote for tomorrow that would step toward that thing that I think is something that people who feel meaningfully better from an intervention like, again, it's a technology like the technology that is LSD or MM120, or the technology that is good dynamic psychotherapy. I don't think it has necessarily an actionable political orientation, but I do think that the capacity for closeness to oneself and therefore the capacity for true closeness to one another is ultimately societally a benefit, and is in some sense, given the politics of our country, of the world, of whatever metastructure you want to draw around that analysis, is a good thing.
bracketing the kind of utopian fantasies that Patrick is talking / warning about. MindMed's clinical trials they're really impressive. The results are really impressive. And, you're at a very interesting moment. I would love to hear you speculate about what is next in terms of psychedelic research and its therapeutic potential, both in the short term, but also in the longer term. I mean, another way of putting this that's less like, please account for whether or not like the psychedelic renaissance is coming, because that's not really what I'm asking. It's more a question of like, what are some of your hopes and fears and worries or predictions for the future of psychedelic research as somebody who has been in this world and in this project for the last 5 years?
Yeah, there are the more predictable nearer term things. So we have 3 phase 3 studies that are running now. We're running very regulatorily relatable, familiar looking studies that despite the some of the exceptional outcomes we've seen across the research that people have done in the category, a lot of that has not been done in a way that is familiar to regulators, that's familiar to potential prescribing physicians, that's familiar to payers. And those are all stakeholders in this too now. So we conduct those studies with as high fidelity and high integrity as we're capable of. We try to make the studies with long before I got involved in psychedelics, I was doing a lot of measurement for research. So how do we measure things in a more fine-grained way, temporally fine-grained, spatial, whatever. And I would joke that, like, if we're going to apply one novel measurement technique in the study, that's the one weird thing we're allowed to do, and everything else in the study has to be as normal as possible. For the last 5 years, I've been able to say, I think the fact that it's LSD is my weird thing. The rest of the study needs to be as normal as possible. And what we've been able to say, based on the research we have ongoing, is that we expect to get to data next year. So we have one study that will read out in the first half of next year and 2 more reading out in the second half of next year. Those data serve as the basis for an application to healthcare authorities, FDA being the main one, obviously, and our targets being a US company. That application takes the time it takes to be considered. FDA has, it's such an interesting thing in the development of drugs and thinking about the role of a regulator, because these are long-term projects. So it actually brings our interests and the regulators' interests to sort of the same side of the table, where we're different stakeholders in the same process. Because if I don't have a successful body of evidence that I can show them, they shouldn't approve the drug. Similarly, they would like to be able to approve drugs that are safe and effective to uphold their public health mission. So that interchange, the informational exchange, and the gaining alignment of what that evidence could look like is a two-way street. And you need the agency to tell you today what they're going to continue to want tomorrow, because tomorrow can be far away. And that long-term consistent engagement, so you're speaking the same language, having the same conversation day in and day out, so that when the time comes, you know that if the science that you've done produces a certain outcome, that you're going to be able to go work with them to come to label guidance for prescribers to potentially use to prescribe the drug. And then that becomes also conditions, essentially all of that, the labeling, what's called a risk evaluation mitigation strategy, which is guidance for people who are administering the drug or writing prescriptions for it, all become the framework for what is demonstrated through the evidence to be the safe and effective conditions of administration. And we have certain objectives that we'd like to demonstrate for what the sort of minimum, this is what we've talked about a lot today, what's the minimum amount that needs to be done for the drug to be safe and effective. And then in my optimism for the future of psychiatry and all the psychological professions is, okay, now figure out what to add to make it even better, right? And figure out how to deliver this efficiently. And I mean, Patrick, you said scale, and scale is such an interesting word, because it's what an odd concept to be looking at how we can get people a treatment at scale when that treatment happens to be LSD. But is there a way to make it safe and effective and controlled on an ever broadening scale? And this is most important, I think everything that we do from a research perspective ultimately has this goal, which is, can the people who are suffering the most, the people who have the least access today, the people for whom effective treatment is not out there waiting for them, can they get access to this because we've made it such that payers, particularly state-sponsored payers, are eager to treat people with this? And that argument becomes, in this paradoxical way, a financial one, right? If we help people to be better, they end up costing you, payer, less. And what a strange world to live in, where on the one hand, I'm really deeply invested in helping the few people I do treat now to feel better. And I don't really think about it from a what's the financial argument for doing that standpoint. But on the other hand, we need to, in order to get the poorest people access to these drugs, we need to be able to make an argument for why it's better for, big air quotes, the system, for them to feel better. But that doesn't mean we necessarily want to say that their material conditions are okay just because they feel better. And I would hope that by feeling better, people are in even better position to improve those material conditions or to express their discontent with the material conditions that they and their cohort, however you want to define that, have been put in.
Dan, thank you so much. This conversation has been so unbelievably rich. It's just been such a pleasure.
Really.
Yeah, thanks for having me. I don't often get to be on a podcast that I really value and that means so much to me. And you all and your guests have been my psychotherapeutic colleagues, in essence, in a parasocial way, admittedly, but I guess until now. But as someone who is pretty far from having a practice community and people who I talk about cases with, things like this, you have served that role. So it's a tremendous honor to get to be here and share all this with you and with your listeners.
Thank you so much for listening to this episode of Ordinary Unhappiness. Ordinary Unhappiness is made possible and kept completely ad-free for everyone entirely through the support of our Patreon community. If you'd like to support the show and get 2 additional episodes per month, including our ongoing journey through the standard edition, please come find us at patreon.com/ordinaryunhappiness. This has been an episode of Ordinary Unhappiness, a podcast about psychoanalysis, politics, pop culture, and the ways we suffer now. I'm Abby Kluchin, and today I was joined by Patrick Blanchfield and Dan Karlin. This podcast is produced by Dan Yowell. Theme music by Formal Chicken.